Hi, I'm Dr. Robert Kaufman, and we're about to go beyond the terminus. One of the most useful tools of last resort in endodontic therapy is the ability to quickly and effectively provide profound anesthesia through the use of an intrapulpal injection. This method should only be used when all other methods of anesthesia have been unsuccessfully tried. If you're routinely finding that your anesthesia is inadequate for endodontic procedures, such as mandibular blocks or maxillary molar anesthesia, most often the problem is with your anesthesia technique rather than the patient or the solutions that you're using. Anesthesia technique for routine endodontic procedures is beyond the scope of what we'll be discussing today, but even with the best technique, there are sometimes situations in which profound anesthesia seems to be present. Pulp continues to be acutely responsive. It is my opinion that intrapulpal anesthesia is a much preferred method over repeated, unsuccessful injections that are not effective and serve only to make patients' soft tissues uncomfortable after the procedure. Protracted attempts to access or instrument canals with sensitive vital tissue is not only painful to the patient, it is stressful to the clinician and especially to their staff. You're much less likely to create an optimal endodontic treatment when the patients are jumping around because they're uncomfortable. The theory behind intrapulpal injection is to rapidly raise the pulpal pressure beyond the trigger level of the pulpal pain fibers. Once this level is reached, the nerve depolarizes once and then is rendered unresponsive. Studies have shown that this can be accomplished with any liquid, such as saline. Anesthetic solution is generally used because of the convenience of applying it via the needle and syringe. There is no question that the patients experience a momentary sharp discomfort. In cases of a hot tooth, especially lower molars, the anesthesia achieved with this technique is profound and immediate. There are several keys to getting good results with this technique. First of all, number one, always warn the patient they're going to feel two sharp sensations, lasting only a second or two. You must prepare the patient first. Secondly, remove the existing restoration. Try to avoid dentin. Again, warn the patient that when you're about to penetrate the dentin or expose the pulp. Choose the highest pulp horn or area where the dentin is the thinnest. Quickly expose the pulp with a new round number 2 burr, dry, turning at maximum speed. Use a jabbing motion with the burr. The patient will start for a moment. Reassure them. Thirdly, do not enlarge the exposure site. It is important to be able to lock the needle into the exposure. Use a 30 gauge short needle and apply a right angle bend. If necessary, apply pressure to the area of the bend with your opposite index finger or thumb, forcing the needle tip into the exposure site. Always warn the patient first before you inject. The patient, again, will feel a momentary sharp sensation as the needle is introduced and the intrapulpal pressure exceeds the limit of depolarization. Now the anesthesia is complete. With proper technique, anesthesia will be profound along the entire length of the canal. In some calcified multiple canal cases, it may be occasionally necessary to supplement this technique with individual intracanal injections. Be careful to inject only in cases where there's vital tissue. You do not want to do this with necrotic contents and push the contents apically. Only a tiny, minute amount is necessary. No caring clinician ever wants to make patients uncomfortable. I think it's much kinder to patients to perform this procedure, which lasts only a moment or two, as opposed to continuing any procedure in which patients are uncomfortable and the anesthesia is inadequate. The patient gets frustrated and you get frustrated, and that's not a good combination. If your dentist is performing procedures and you're still uncomfortable, tell them to stop. There are ways of ensuring that the procedure is totally comfortable and it's not the patient's fault. If the clinician is unable to obtain adequate anesthesia, the patient should be temporized and referred appropriately to someone who can provide the service in the most comfortable manner possible. Remember to treat patients as if we want to be treated ourselves. When we do the right thing, we both get better, patients and clinicians. Thanks for listening, and I will see you next time when we go beyond the terminus.